Super. So hi friends, thank you so much for joining us today. This is the 12th CIDsCaNN educational session and you're really in for a treat. Next slide, please. So please remember to keep your microphone muted and put your questions in the chat. Questions will be discussed during the meeting and at the end. There is CME hours, so remember to do the feedback at the end so that you can get your certificate. Next slide. As usual, we're going to be doing Slido again. So if you could join using the QR code, the number today is 3159442. We'd really love you to kind of get involved in the discussion. And I think, Michelle, you've maybe got a Slido question for people to join in with? Okay, so just to get us all used to using Slido as usual, how do you best define your role? You can join using the QR code or using the number through slido.com.
I wish I'd known you were doing this. I could have given you a Scottish trivia question to do for
yeah,
this.
That would have been an excellent
warm-up.
start.
Sorry, didn't know that.
The answer is Iron Brew.
Excellent. We've got 15 participants. There's 30 of you here. So a whole range today, which is totally fantastic. Excellent. So continue doing that during the session. We really want you involved. Super. So it's a great pleasure to welcome our speaker for today, Professor Richard Russell. He's a consultant pediatric gastroenterologist at the Royal Hospital for Children and Young People in Edinburgh. He leads the Porto ESPGHAN group, and that group really generates collaborative pediatric IBD international research, which is fantastic. He's extremely well published in the field of IBD. He's a fab teacher and collaborator, as many of our Canadian colleagues can attest to. So Richard, thank you so much for joining us today to discuss controversies in pediatric ulcerative colitis. Thanks so much.
Thanks so much, Sally, and to everybody in CIDsCaNN. It's a great pleasure to be here with you this morning, afternoon, evening, like we all are. Next slide, please. So I have disclosures to make. They are relevant to some of the things that we'll talk about. So some of the therapies I will talk about are made by some of these companies. As Sally has also said, I'm chair of the Porto group and have been part of that group for more than a decade. I'm sorry if I have a bias towards the work that comes out of that group, so apologies. I've tried to be as broad-minded as possible, but I do have an inherent bias towards the studies that we do and guidelines, so apologies. Please slate me at any point needed. Next slide. I think between Scotland and Canada, we have a great affinity and we've worked together very well. I think your CIDsCaNN Network and Education series is a great thing. And I think collaborative research across countries really shows the strength of the countries we're in. We have that in Scotland, you have that in Canada. We both have two large focal countries to the south of us who don't have that. So I think we should be proud in all that we achieve. And I'm particularly glad for all the collaboration with the great colleagues in Canada that I've had the pleasure to work with previously, now, and hopefully in the future. Next slide. So if you just click on into the slide, that would be great. Thank you. So I've given Sally and the education team gave me the topic of, I guess, new or difficult things in colitis. And I know so many of you that it's very hard to teach you something new. So I have based a lot of the talk on a couple of real cases from Edinburgh with real challenging features in them. And then I have, if we have time, a made-up case at the end. So this is a nearly 5-year-old who had presented with 2 months of very significant bloody diarrhea and weight loss. The parents were from sub-Saharan Africa, and they spoke English. Dad spoke English, mum not so much, and they had presented several times to the emergency department, and perhaps because of language issues or other things, they weren't really moved on with investigation. So this child came to the outpatient clinic after a routine referral. It was very clear when we saw them in the outpatient clinic, they were unwell. If you just click on. And the initial investigations, I hope these translate into the values that are recognizable to you. So she had a very significant iron deficiency anemia. She had a very low albumin. Her CRP wasn't that high. We did an ultrasound to start with, which just showed thickened bowel throughout. Stool cultures were negative, and calprotectin was significantly raised. We spent the first part of dealing with this child really with resuscitating them. So came into hospital, had some iron, had some blood, had some cautious feeding, and then some non-invasive tests before we undertook a sigmoidoscopy, which showed a very severe colitis to the limit of our examination. Next slide. So what I want to ask you, and you're going to think this is a cheeky question, but it's not really. So go with me at this stage. So what would be your initial medical treatment if this child presented to you wherever you work in Canada? Would you use methylprednisolone or an equivalent steroid, infliximab, tofacitinib, or would you send them straight to the operating room and have the surgeons do a colectomy? I think the person who put methylpred in the chat, I think you're meant to vote on Slido. I think that's the that's the idea. Okay, so everybody bar 1 or 2 people did methylprednisolone. Can the person who said infliximab, or the 1 or 2 people who said infliximab, do you want to come on the microphone and say why? I guess that's a no then. Okay, next slide. So these are, and I have a few of these in the talk. So these are the upcoming, yet to be published latest version of the CIDsCaNN and ECHO UC guidelines. So this is the 3rd time that they'll be published. I don't think anybody will be surprised that the steroid statement really hasn't changed, because we haven't done many new studies on steroids, apart from some people trying to use very high doses, which we'll describe in the paper as really making no difference. So this is standard care, and I don't think any surprise to you. What we were trying to do with this guideline is to say, are there children who have such severe disease at presentation, should you just miss steroids out? And should you just go straight to infliximab? Because it's inevitable, really, that they're going to need infliximab. And in terms of infection risk and other risks, steroids, carry probably a greater risk than giving infliximab. So we try to look at and generate evidence with that in mind, but we couldn't really find any, it's fair to say. So we came up with this kind of cop-out statement of second-line therapy should only be used if you have a contraindication to steroids, which was not really what we were aiming for. Next slide. This is one of few adult studies which have really tried to look at using anti-TNF as first-line treatment in patients. And really what they were saying here was people with high risks for VTE, so not directly addressing, the question we're asking, because of the risks associated with steroids and clots, then they would be a relevant group to treat with first-line biologics. But that's not really, what we're asking. And I think moving forward, I do think there will be a way to predict patients who inevitably are going to fail steroids. So in a standard acute severe colitis data set, then that would be 30%. But in patients like our girl who are very severe at presentation, can we predict from their parameters at presentation that they're so bad, we may as well just put them to infliximab treatment. So I thought about this in this patient, and that was one of the reasons we brought it to the guidelines. Other people were thinking the same, but we haven't been able to answer that question satisfactorily, either with pediatric or, slightly more surprisingly, adult studies. Next slide, please. So in this same patient, and I want you to be honest because there's no point not being honest, what would you do about preventing thrombosis? So remember, she's under 5, she has acute severe colitis, she's hospitalized, and she's getting blood and steroids. So you have a choice of doing nothing, you have a choice of hyperhydrating her, you have a choice of a heparin infusion, low molecular weight heparin subcut, or DOAC, so direct oral anticoagulants. So do you want to have a little go at that tricky question? That might be enough, Michelle, to give us a flavour. Okay. So vast majority of people want to do nothing, with second favourite low molecular weight heparin. Okay, great. That's really helpful to know, and we'll look at the incidence and the evidence on the subsequent slides. Next slide, please. So I think one of the difficulties with this type of work is trying to find the proportion of patients who develop clot complications with colitis in hospital. So you can see we have a Danish population study first, and then if you click next, then we have a Canadian study coming next, and then click again. We have the prospective study set up from PIBD set quality, which has brought, I think, the widest data set with some idea of a denominator. So the risks between these studies and surveys vary, no surprise. They all show an increased risk. They all show that colitis has a greater risk than Crohn's disease, and the number of central clots in children is significantly higher to the more peripheral typical DVD or pulmonary embolism that you will see in adults. Patients usually have active disease, they're usually in hospital, they're usually on steroids, but there is a spread over different ages. So particularly, I think, in the prospective, this published study, and then the subsequent study, which is coming but is not yet published, it's very clear that the age range that these clots can happen at are really overall ranges where acute severe colitis can impact on children. Next slide, please. So there is a risk, but what should we do about it? So what do adult guidelines say? So the adult ECHO guidelines say anybody hospitalised with active UC should go on to prophylaxis. Canadian statement fairly similar, and there applies to IBD overall, not just ulcerative colitis. And again, then a consensus statement that's saying the same thing. So in adults, the evidence is clearer, and the effective treatment with low molecular weight heparin is clearer too. Next slide, please. In children, in our last version of the joint ECHO and CIDsCaNN statement, we sat on the fence a little bit, and we really said that for younger children, we're not sure that we should be giving them prophylaxis, but for children aged 12 and over, then it would be appropriate to give them or think about giving them prophylaxis. The Canadian statement that we found before, you said not to give it to anybody under the age of 18, yes, unless they had developed a DVT or they'd had one in the past. And then if you click again, then the recent RAND panel statement from a couple of years ago was pretty similar to the CIDsCaNN statement, so post-pubertal, so over 12s were getting treatment, and under 12s not really, unless they had lots of risk factors, and a lot of the risk factors on the slide won't apply to under 12s, as smoking and oral contraception. So things hadn't really moved on that much. Next slide. So this is what we're doing in the current guidelines, are suggesting that we do, and we've pushed things a little further with this statement. So we're suggesting that anybody of any age with acute severe colitis, so using your PUCAI score as you'll be used to, should be given pharmacologic thromboprophylaxis. And that should be in low molecular weight heparin, and you can see on the screen the dosing there. So once daily for older children, but maybe for younger ones, splitting the dose into two. So these are not yet in press. They have been voted on and agreed, as you can see. So I don't think, and I don't anticipate going through the further peer review process is likely to change those, but they're not set in stone yet. But I wanted to give you an idea of what's coming. Next slide. And in the guideline, we've given a flow diagram, really not to help with so much with patients with acute severe colitis, but what do you do with other patients whose UC is bad enough, but they don't have acute severe colitis? So there may be some circumstances where you want to give them prophylaxis too, and this diagram helps you making that decision. So I think the guidelines have moved us one step forward, and I think particularly for patients, and clearly most of you think so too, patients like this you wouldn't have given thromboprophylaxis to in the past, maybe just think about it now. Next slide. So in our patient, what happened to them and what did she do? Well, she did get methylpred because I wasn't brave enough to give her infliximab straight off. She actually had bilateral thrombosis really at presentation. So we treated her with low molecular weight heparin, but she wasn't in hospital long enough for prophylaxis before she developed those. And surprise, surprise, and what we thought was she wasn't likely to respond to steroids and she didn't. So I don't think it's controversial to say that she got infliximab next. I think most of you would go to infliximab next. Next slide. But I just want to show you exactly how we did this. So the question in the chat was, we saw the clots on her initial ultrasound. So she had an ultrasound done to look at her bowel wall thickness to try and give us we weren't too keen to scope her immediately. We wanted to resuscitate her. So the ultrasound was done on admission, and the clots were seen on that ultrasound, although we didn't ask them to look for them directly. We were looking at the bowel. They picked up the clots as well. So thank you for the question. We gave her very big doses of infliximab. So this was me supervising the initial dosing. So you can see our first dose was 20 per kilo. 3 days later, the same dose. 4 days later, the same dose. And we were getting signs of clinically improvement, and on blood tests, particularly her albumin, because her CRP wasn't so raised, her albumin was a helpful marker of improvement. But as it started to dip, then we gave some more infliximab. So in the first month post-diagnosis, she received a total of 80 milligrams per kilogram of infliximab. As we were waiting on a full infliximab effect, we did also add in quadruple antibiotics, so Jerusalem cocktail, as you'll be used to. We started a thiopurine, and we also added in some mesalazine enemas. It worked. I was very worried that she was going to need a colectomy. I haven't gone through the referral to the surgeons, but the surgeons were made aware of this patient on admission and kept up to date with her progress. She went on to standard dosing infliximab after this initial month of 10 per kilo 4 weekly. And you can see we got her dosing pretty right. And I was happy that by the time we came to our 6th dose, we were really where we wanted to be with maintenance. Next slide. So how did this patient end up? Well, she's 6 now and doing very well. So she's on infliximab monotherapy, standard dosing, 6 weekly, completely normal calprotectin, normal bloods, going to school, and you wouldn't recognise there was anything different to her compared to other children. So I think she demonstrates a case that I don't think you can be much closer to colectomy without colectomy, and I think she's probably one of the worst cases that we've successfully rescued. And I think there were a number of important features in there which helped with the rescue. So I hope that case has been helpful. We're going to go on to another case now. Next slide. So this guy already has a diagnosis of colitis. I walked you through the first one for reasons I hope you have appreciated. But this guy was 13, moderate activity, left-sided colitis on scope, pre-diagnosis problems with selective mutism and anxiety, including procedural anxiety around bloods, treatments, including colonoscopy. His father, predictably, was a general practitioner, a doctor, and his mum already had a diagnosis of colitis. We were not able to do pre-scope bloods, but we did bloods with his scope and took off every blood test we could think of. He was initially treated with steroids and then on to oral and topical mesalazine for maintenance. Next slide. So nothing too exciting so far. He flared again on his mesalazine prophylaxis. He went on to a second course of oral steroids as an outpatient, but he didn't respond and then came in with a diagnosis of acute severe colitis. His problems were significant, so even for us to get blood tests, he needed sedation with midazolam. and we put in a cannula and did bloods at the same time. He needed infliximab rescue. He had a few doses of IV steroids, didn't respond. And so he got 1 dose of infliximab, and then, of course, despite everybody trying to keep his cannula in, it came out. Next slide. So I've given you a difficult patient situation now. What are you going to do with this guy? So will you put in a central access device? So I don't know if portacath is what you would call a device, but a central access device, a permanent, semi-permanent access device into a central vein. Would you switch him over to adalimumab, knowing that he will have a degree of needle phobia, but maybe you could get round that? Should we sedate him every 2 months and give him cannulas in bigger doses of normal than infliximab, or do you want to do something else? So there's your dilemma. Real case, remember, real case. I'm interested to see what your answers are. And if it's any help to you, I chose the wrong option. Okay, nice work. So most popular answer is to switch to adalimumab. A lot of people want to do something else, so I haven't supplied you with enough information. Interesting. 20% of you would sedate him and give him cannulas, and I think in parallel to that, we'd also put in a semi-permanent device. Okay, there's too many of you want to do something else to allow me to explore that with you, but maybe one of your options was what I'm going to show you on the next slide. So it's fair to say these were long and difficult discussions, which took many hours. We went through the different routes and the strengths and limitations of the therapies. Dad, being a medical doctor, had some strong views about licensed and unlicensed products and products delivered at hospital or at home. So in the end, as a compromise, this patient got subcut infliximab. So I'm just going to go into that in a bit more detail on the next slides. I'm not sure how familiar you are or how often you're using this, so I'll just go through a few slides just to bring everybody up to speed, really. So this was licensed 4 years ago in adults. It doesn't have a pediatric license anywhere to my knowledge. It's a fixed dose of 120 milligrams. It's normally given every 2 weeks, but some groups have given it weekly. There is very strong adult evidence for this. So RCTs, meta-analysis, systematic reviews, and lots of real-world studies. Next slide, please. And this is the registration study. So essentially a non-inferiority trial pairing patients between standard IV dosing and subcut dosing, and showing equivalence in terms of drug levels and also in terms of PK profile. You will see that the maybe appreciate on the graph there that the drug levels subcut tend to stay higher, so you don't get the same peaks and troughs as you do with IV. Next slide, please. And just to show you, the strength of the evidence, you can see there are lots of studies that have gone into this. So I don't think we're in any doubt really that we're comparing like with like in terms of drug levels and efficacy. If you just click through and click on again, thanks. So I just want to take you through our paediatric cohort that we've used this as an off-license preparation in Edinburgh. We published a very small series of 7 patients initially, but this represents a wider experience which is not yet published. So over 3 years, adolescent IBD patients, so not all of our paediatric clinic, standard dosing, fortnightly 120 milligrams, and looking at short and medium-term response in terms of disease activity and other measurements. Next slide. So we have 27 patients with the usual spread of a paediatric population, so most with Crohn's disease, but you'll see a colitis experience there. Different to our standard population, so these are slightly older and they're slightly heavier, and that's because we targeted this therapy at our older patients initially. Initially, we did a switch program, so patients to be eligible for the switch were over 12, over 40 kilos, in luminal and hopefully luminal remission if possible. We still use co-immunosuppression in Scotland, so different to your guys' experience. And the standard patient was on 10 milligrams per kilogram 6 weekly of infliximab at the time of the switch. Some people had IV cannulation issues. Some people came geographically from a long distance, so perhaps particularly applicable to your Canadian population. And some people just preferred to give injections at home rather than in hospital. Next slide, please. So essentially, the treatment persistence with subcut is the same as the treatment persistence that you get with IV, is our experience. We made a mistake. So there are 3 patients who stopped. We made a mistake with the first one. So this was a prospective experience, and we collected drug levels, of course, before the switch. But what we didn't do with our initial few patients was wait on the result before we gave them the subcut. So we've learned from that, and we don't do that until we have the result now. So this first patient had immunogenic loss of response starting before we did the switch. So we were always going to fail with that patient. So that's a lesson: get your level and antibodies before you switch. The second patient was transitioned, and what I think the transition adult gastroenterologist should have done with this patient was to increase them to weekly rather than switch them out of class, which might have rescued them. And then the last one, it's fair to say this doesn't suit everybody. So there are some patients who don't enjoy the subcut experience, and this is one of a couple of patients now who have wanted to switch back to IV. So I think that is an honest experience of what's happened. Next slide, please. And in terms of effectiveness, then, as I say, really it matches what you would expect from IV. So you will see secondary loss of response, as you would expect, but that is no different to our IV experience. This wasn't a paired study, so we haven't compared this to IV patients, but I think you'll probably agree with your own experience. This doesn't look dissimilar to that. Next slide, please. In terms of drug levels, the issue for us is that our assay has a very short limit on it. So it doesn't measure above 14, which particularly for subcut levels is no good. So we learned again in our first pilot of a few patients that this wasn't going to be any good, and that we needed, next slide, to dilute our samples really. So if you're not used to subcut levels compared to IV, a median subcut level is more towards 20 than what we would be aiming for our standard patients, which is towards 10. So whether we need to run it at that level, I think we'll find out in the fullness of time. But our standard patients on standard dosing came out with those levels. Next slide, please. So the drug costs themselves are fairly equivalent the subcut is very slightly more expensive, but not significantly in the grand scheme of things. So drug costs are comparable, but you'll appreciate the indirect costs for subcut are much better. So patients don't have to travel to hospital, so no time lost for parents or patients for IV infusions. Obviously, they still come for routine checkups, so it doesn't go to zero, but the travel time and the greenhouse gas effect is very good. So our carbon footprint improves with using subcut. Next slide, please. So our summary of our experience so far is this is a useful treatment option for some patients. We've chosen mostly to do patients who are in stable remission on IV, but actually now we will choose to push some patients into subcut early on in their disease course. So we have given some patients subcut from dose 3, so 2 IV doses, and then on to subcut. We certainly don't think there's any increased risk of immunogenicity, and theoretically there might actually be a reduced risk. So for a lot of our patients who are on combo therapy, we then will stop their azathioprine if they're still on it at the point of switch fairly quickly after we've established good levels. And then the indirect costs obviously are much better. Next slide. So if you're thinking about doing this, then we can loan you this kind of flow chart just to work your way through. You would need it particularly for your first 5 or 10 patients. So just to think through all of the different considerations if you're going to use subcut infliximab. So don't read this, but it's just to say people have asked us, you know, if we're going to do this in our patient population, what are the considerations? So this is a flow diagram to try and help that. Next slide. So what happened to our patient in practice? Well, he wasn't the easiest patient for the reasons that you've heard about already. The IBD nurse gave the infliximab at the hospital initially, and then the dad used to give him it at home, him being a GP. This wasn't a perfect solution, but there didn't seem to be another good solution for this patient apparent to us at this stage. And it was taking a lot of nurse time and causing a lot of parental angst and a degree of disharmony between the parents. Despite his infliximab, he then had a further flare. And at the point of flare, he'd experienced mesalazine, top and tail, 2 courses of steroids, and infliximab. So you can guess what the next slide's going to be. This patient now becomes your virtual patient. So what are you going to do next? So are you going to reassess him and, if indicated, switch out of class? All of you people who wanted to give adalimumab in the first place, are you still as keen? Are you just going to take a practical solution and give him a further course of steroids? He's responded before, and stick with infliximab as a compromise treatment, or are you going to do something else? Okay, so most of you want to switch out of class and go to another biologic. I'm guessing vedolizumab might be high on that list. 15% of you want to do something else, and are there data to suggest that subcut infliximab, unlike subcut adalimumab, is as effective as IV? So that's a question for from Anne Griffiths, and I'm going to answer that towards the end, I think, just so I can fully understand the question. So everybody who wanted to switch to adalimumab is now put off by this situation. So most people want to reassess and move out of class. Okay, next slide. Okay, so this is this boy's real life calprotectins. So you can see at diagnosis, he was given steroids, put on mesalazine, flared, and then went on to infliximab. The third peak you see on the slide is the point that I'm asking you the question at. And then you can see we've chosen a marvelous treatment that immediately put him into deep remission, and he's remained in deep remission. And we took away all of his other treatments and only remains on this treatment now. Anybody want to guess what that treatment was? You can put that in the chat. Okay, JAKs are popular. We're coming on to JAKs in a minute. It's not a JAK. Anybody offer something that's not a JAK? It is an oral medication. Okay, so Uste, no. All right, I'm going to put you out your misery. Next slide. So I don't know if it shows to you. It's off the bottom of my slide, but I hope you can see it. It's vancomycin. So we gave him oral vancomycin, and as matches our experience, you get a very binary response to this. So it either makes no difference or it makes a huge difference. So we gave him 250 milligrams initially 4 times a day. He's now down to 3 times a day, and then long-term deep remission only on vancomycin, no mesalazine, no infliximab, nothing else. Next slide. So I'm coming off the fence in terms of how we treat UC. My opinion, the Edinburgh team's shared clinical experience, this is not perfect, but it does allow us, if we're doing standard treatments between us in a consensual way, to then learn what works well and what doesn't work well. So for UC, we would always use azathioprine, not methotrexate. I'm sure that will be very controversial for you. I think there is good evidence that infliximab is better in a colitis situation than adalimumab, and the new guidelines are going to say that for sure. I think vancomycin, I feel awkward about, because the published experience of vancomycin is increasing, but it's not really at a point where I can say robustly this is definitely a good thing. But honestly, before I worked in Edinburgh 4 years ago, I never used it. And coming to Edinburgh, I thought, I don't really think this is a good thing, guys. Where are you getting this strange treatment plan from? And actually, for some patients, it works remarkably well, even after biologics, like you have in this child. So I think before you get into more significant and difficult therapies, a 4-week trial of vancomycin for a lot of patients would be relevant. I think if I was positioning it, ideally, I would give it after mesalazine before steroids. Somebody's asked, do you give Vanco alone versus a Jerusalem cocktail? So for patients who don't have acute severe colitis, then it's given as a monotherapy, not as a combination therapy. Sometimes for patients who have a acute severe colitis, they respond to the cocktail, and we give them vancomycin as maintenance beyond the 3 weeks of the quadruple therapy. And then beyond that, I would try and get the patient into a clinical trial with all the issues that relate to that, and we'll come on to one slide about that. And then beyond there, in the order that you see them, so I still think vedolizumab would be your next line. For JAK inhibitor, upadacitinib only, tofacitinib, doesn't seem comparable to upadacitinib in our experience. And then you come on to ustekinumab, which was, or trazimod, which was some of the suggestions on the chat. Vancomycin is not an expensive treatment in Scotland, which was one of the questions. Next slide. So what do we have for vancomycin? Well, we obviously know the experience as part of the Jerusalem cocktail, and it has been used, in some very early onset patients. But sorry for the typo, but PSC is really the place that it's best known. Next slide. And Amanda has led and published this beautiful study this year. I'm not sure if she's on the call or not, but this is some of good evidence to start to suggest that, the vancomycin, which was really there for the PSC and IBD related to PSC, seems like it's a different disease, but intestinal inflammation, particularly colonic inflammation, does in a subpopulation of patients seem to respond to vancomycin. So you can see the difference of vancomycin experience in terms of remission rates, which are double those of inexperience. So we do need better evidence, but I do think this is a useful part of practice for some patients. And I don't like individual patient experience, single cases changing experience. So next slide, we're moving on to try and give you an honest and collective experience of using this in Edinburgh IBD patients, not in PSC patients. So we should be able to show you that data at the meetings next year and give you an idea of really how effective it is in a population sense rather than just in individual patients. Next slide, please. I just want to have one slide about clinical trials. We've all are trying to get our patients into a wider array of these clinical trials. It's particularly hard in colitis because we have so few patients, and it's particularly hard in colitis because we have so many new agents that are trying to get past the point of license. So I think this is particularly difficult, but particularly important at the same time. So I do think we should try and participate in these trials. But the other side of that is the regulatory agencies and the companies need to come with us. And we're currently trying to make these trials easier, as we have done for 2 decades, but we continue to be in discussions, and Dan in Europe and Eitan in Canada and Jeff Hyams in the US, we've all put together a similar consensus response to the recent FDA publication about how to do paediatric trials, and a bigger document to follow on from that is there too. So we've managed to advocate for change over time. It's very slow. It doesn't seem to really, we're in a pickle at the moment, and really the time towards licenses is increasing, but it's important we don't forget this as an issue. Next slide. So what I did want to give you, because Sally told me that this would be particularly relevant for you guys, is just to give some JAK experience. And as I say, our main JAK that we're using just now is upadacitinib. We would have access to filgotinib and to tofacitinib, but the upadacitinib we found is particularly good and seems, from the clinical experience in adults, it does seem that experience translates into children in a similar way. So this is one of our CIDsCaNN special interest group studies. So we have 90 patients with UC who have got upadacitinib, and you can see on the slide just the summary there about the kind of responses you're getting at 8 weeks in patients with colitis. The manuscript is under review at present. Do we have access to UPA in all ages? Yes, we do. But it's more difficult for the younger patients, partly based on, what dose would you actually give them. And for patients under 12, we would push them more towards a clinical trial, ideally, rather than give them open label experience in standard clinical practice. Next slide. And you can see the effect on the disease activity score. Next slide. And the impact on calprotectin from the patisitinib as well. I realise I'm coming fairly close to time, Sally. I'm happy to stop there and try and answer some of the questions. Would that be the best thing to do at this stage?
Yeah, I mean, that's really excellent, Richard. Thank you so much. I think it would be lovely if you could answer a couple of questions, and
Sure.
had a very interesting point. Richard, I don't know if you want to sort of take a stab at answering Anne's point in terms of data to suggest that sub-Q infliximab, unlike sub-Q adalimumab, is as effective as IV infliximab in inducing remission of active ulcerative colitis.
Maybe I could explain the question a bit, could I, Richard? Yeah, thank you. That was beautiful cases and very well delivered. So what I was asking was, you showed very nice data on switching to subcut in people whose colitis was well controlled on infliximab. Your index case, I think, had kind of active disease. And so what I wondered was, when we're faced with active disease, is subcut infliximab a comparable option to IV? Which might be just a little bit surprising because, as you pointed out, the subcut anti-TNF that we've had, adalimumab, probably isn't as reliably effective as IV infliximab. So that was the question. Subcut infliximab for treating active disease or just after you're in remission?
Yeah, so I think for our, is it possible just to stop sharing the slides and then we can see a wider picture? We deliberately targeted our studies, towards switching because it's an unlicensed preparation, and we wanted to gain experience in that area first before we chose the kind of hotbed of, using it as induction and then maintenance before we've established an IV. We've done it in a couple of patients. They've had Crohn's disease. The adult studies would suggest you can use it in the same way. So a lot of the adult studies give 2 doses IV and then move on to a subcut from there, and their post-induction and their medium-term maintenance figures, to the best of my knowledge, are the same. So I think you can use it in that way. I think, you gain clinical experience from your own cohort as well. And, after we'd done, 20 or so patients, then we felt experienced enough then to put it into that kind of clinical situation that you described. It is odd, perhaps, that, infliximab seems to be better than adalimumab, even if you're giving it in the same way, because it's first generation versus second generation, and usually second generation is better. But for some reason, the data does seem to point towards that for whatever reason. It doesn't make, great sense scientifically, but clinically that does seem to be the case.
Thanks, Richard. Can I ask a follow-up question? At ECHO, they presented the REM switch long-term data, looking at outcomes in patients who are on optimized infliximab, so 10 per kilo Q4 or 6 weeks. and they were significantly more likely to have relapse and require optimization. A good proportion, up to about 80%, I think, did regain recapture response when they went to weekly dosing. I just wanted to get a sense if that was something that you had noted, especially as in peds, we're often using optimized infliximab in our patient population.
Yeah, so I think thank you for the question. I think, we were very conscious that we use higher doses on average than, adult patients. So we're, 10 milligrams per kilogram 4 weekly is a very common dosing for us compared to adult populations. I think, our population is also significantly lighter though. So trying to match up those two things, that there isn't an easy way to do that. I asked the clever people to see if they could work that out, but there isn't an easy way to translate that into your fixed subcut dose. Our experience is that we've only had to escalate 2 of our patients to weekly therapy. But if you imagine heavier adult patients, it's no surprise to me that some of them need weekly therapy. And in the study that was done from Liverpool, they did it in reverse. So they gave the vast majority of their patients who were on optimized dosing weekly therapy and then stepped them back. So I think within pediatrics, as long as you have good access to levels, then you're safe to do whatever you want. But for some of the bigger adolescent males, we have had to put them on to weekly therapy. So I think there will be a way to calculate the risk of needing weekly therapy. And I think what you might find is that some people go the opposite way and start with weekly therapy and then de-escalate to 2 weekly, rather than doing the step up that they're doing just now and seeing the the high not fail rate but need for escalation.
Thanks, Richard. Yen, I think you had a question that you wanted to ask. Do you want to ask Richard?
Yeah, so maybe thanks, Richard, for a fantastic talk. Maybe just a follow-up on question that Sally asked. So is there a dose of infliximab that you don't switch? So for example, we often have patient on 10 milligram per kilo Q4 weeks, say, in a IBD patient. Would you switch that patient, or you only switch those, say, every Q6 or less than that for in terms of...
Thanks for the question. We'd be happy to switch patients on 10 per kilo 4 weekly. So that wouldn't be a reason not to switch them. And for the vast majority of patients we've done that in, 2 weekly therapy has been enough for them.
Which is interesting because the switch data in adult trial is different, right? Because a majority of those patients on that dosage require escalation. Very.
But the median weight of those patients compared to the median weight of our patients will be significantly different, which might explain some of the the difference between the two populations.
So just my follow-up question is, because in your pediatric patient that you induce with 20 milligram per kilo of infliximab, and that's, I don't go that high, so I'm just intrigued why you use 20 milligram per kilo at 0.14 weeks for induction. And is that a common practice in Europe? Well, certainly we don't do too much on the West. It's in Canada.
Yeah. So thank you. It's an extreme case, and and I wanted to show you, I guess, difficult cases, because I know you're an IBD experienced group and community. I think Amit Asa has published some nice work, particularly in younger patients, which he published in JPGN relatively recently, showing you do sometimes need those initial doses, particularly. So this patient's albumin was at the very end, at the very bottom of the scale, and to try and get a therapeutic drug level in these patients initially to rescue them, then you do need to use higher doses. So the factors in this patient were very low albumin, very young patient, very bad inflammation. So it's not common for us to use that kind of dosing. Our commonest dosing is 10 per kilo. It's not that uncommon to need to use 15, particularly early in the induction plan. but then you often would de-escalate these patients down to 10 per kilo and widen their interval as well. But particularly in the initial phase where you're trying to combat significant inflammation with very low albumin levels, then you need to give high doses frequently to try and capture response, would be my experience. So it's not common, and bad cases like this are uncommon. But if you're in that situation, you know, you're facing that, or you're facing probably colectomy. So as long as you're weighing up your risks and benefits, then I think it is a reasonable clinical strategy under very, very careful and regular clinical evaluation.
Thanks, Richard. I think it will be interesting as we get increasing data from some of our studies looking at JAK inhibitors, because, you know, especially in our patients who have extremely low albumins, a JAK may well be a really excellent alternative option. There are now some studies looking at using JAKs as first-line treatment in acute severe colitis. The TRIUMPH study is one from Canada that's currently running with good interim data analysis at the 6 months mark. So it will be fascinating to, as we get more data and some of these advanced therapies about that use and how we would sequence in this kind of patient population.
And what it does to the thrombosis risk as well, I guess, would be the flip side of that as well, you know, in this kind of population.
Fantastic. Thank you, Richard. Any final questions from anybody?
So Richard, there's no, if the thrombosis wasn't picked up on ultrasound, will you still thrombopholex? Is that for you?
So I think now I would have done it 2 years ago, possibly not. So I think we've particularly seen, so the second round of data from the PIBD quality set, I think is pretty convincing in terms of, you know, risk at all ages. And I think I was probably, like a lot of people, really focused on, you know, adolescents as part of the risk. I think it's now clear that, you know, a significant proportion of under 12s are at increased clot risk as well. So I think I would now. I don't think I would have then had they not picked it up, is my honest answer.
Thanks.
Fantastic. So Richard, thank you so much for connecting with us, for giving us such a fantastic presentation, loads to think about, lots of work still needing to be done. We'll need to be collaborating with you with your vancomycin work, I think. Really fantastic. So thank you everyone for joining us today. Really appreciate you all joining and participating. If you could complete the post-session survey, we'd really appreciate it. It's in the chat. It's also on the page here. You'll get your CME certificate once you've finished the feedback. Next session is likely to be end of November. And next slide, please. Yeah, so we want to do another trainee challenging cases session. So trainees, please reach out to us. We'd love to get some interesting cases that you've been dealing with locally. We'd love you guys to be presenting. We'll certainly help support you through this. We've had some lots of interesting cases in the past, so I think it'd be really great if you guys can provide us with some more so that we can talk about this nationally. So thanks very much, everyone. Fill out the form, and we'll see you at the next presentation.
Thank you so much. Bye-bye.